Good afternoon, everyone. I now call this meeting back to order. Welcome back, representatives, staff, and members of the public. If you're joining us for the first time, a special welcome to you. That which was true yesterday remains true today. We will proceed with the meeting agenda. This is a public meeting. And please hold your questions, comments until I open the floor up for discussions or until the floor is opened for the public comment period. Are there any representatives present today that were not present yesterday? If so, raise your hand or indicate by stating your name. It's members of NEMSAC only. Larry, do you see any hands raised in the Teams meeting?
No, sir, I do not.
Okay, if none, we will move on with the changes. We will move on. Next, we'll go to subcommittee meeting appointments. At this time, I will announce the names of the members that have been appointed to each of our standing subcommittees. Thereafter, I'll announce the names of the members who have been appointed to serve on the ad hoc subcommittee on ambulance, motor vehicle, crash data, and analysis. Starting with the Professional Safety Committee, chaired by Ms. Jorgensen, Professional Safety Subcommittee, chaired by Ms. Jorgensen, the members will be Dr. McKenzie, Mr. Tagman, Dr. Quintero, Mr. Pfeiffer, Ms. Byers, Mr. Estoshan, Mr. Quintard, Dr. McMullen, and Dr. Orgonzola. Next, the Integration and Technology Committee, subcommittee chaired by Mr. Tom Arkins, Dr. Morshidi, Dr. McMullen, Mr. Estoshan, Ms. Baskell, Mr. Quintard, Ms. Vaughn, Ms. Jorgensen, Dr. Orgonzola, and Ms. Byers. Next, the Preparedness and Education Subcommittee, chaired by Ms. Lisa Baskell, Dr. Owusu-Ansah, Dr. Quintero, Mr. Pfeiffer, Dr. Morshidi, Mr. Gerard, Mr. Miles, Ms. Vaughn, Ms. Jorgensen, Dr. Gestring, and Dr. Orgonzola. Next, the Equitable Patient Care Subcommittee, chaired by Dr. McMullen. Members are Dr. Kohler, Mr. Tagman, Dr. Owusu-Ansah, Mr. Gerard, Ms. Vaughn, Dr. Orgonzola, Ms. Prentice, and Mr. Miles. Next is the Sustainability and Efficiency Subcommittee, chaired by Mr. Brennan, with Dr. Kohler, Dr. McKenzie, Mr. Miles, Mr. Romanello, Mr. Quintard, Ms. Prentice, Ms. Byers, Dr. Morshidi, and Dr. Orgonzola. Next is the Adaptation and Innovation Subcommittee, chaired by Mr. Pfeiffer, with Dr. Gestring, Dr. Kohler, Dr. Morshidi, Dr. Owusu-Ansah, Mr. Brennan, Mr. Miles, Ms. Baskell, Mr. Romanello, Ms. Jorgensen, Dr. Quintero, and Dr. Orgonzola. And now, the Ad Hoc Subcommittee, which is chaired by Dr. Gestring, with members Dr. McMullen, Mr. Gerard, Dr. Estoshan, Ms. Byers, Mr. Brennan, Dr. McKenzie, Mr. Romanello, Ms. Prentice, Mr. Tagman, and Mr. Orgonzola. Are there any questions from the committee? Hearing none, thank you all for your willingness to serve on these committees. We look very much forward to your work and the fruits of those efforts in the coming months. The chair would now like to recognize Kate Elkins from the National Highway Traffic and Safety Administration Office of EMS, who will provide an update on the National Roadway Safety Strategy and its implementation to date. Kate?
Alrighty, thank you. So I think there are the slides. Awesome. So this update is to give you a feel for some of what our office has been presenting both in the EMS community and to the highway safety community. So what's really important to realize is with the National Roadway Safety Strategy, we have this opportunity where the Department of Transportation has really affirmed their commitment to improving outcomes on our highways and our roadways. And this National Roadway Safety Strategy, what's really cool about this new innovation is that they are going to have more emphasis on the development of EMS and 911 systems throughout the Department of Transportation, but especially within NHTSA. And having this highlighted at this level is a great opportunity for EMS and highway safety to collaborate to really improve outcomes for, when we run crashes, we have those really critical patients. It impacts our system's resources, it impacts our mental health. And having opportunities to collaborate at this scale to improve outcomes, both within the EMS and 911 communities and within the highway safety communities, really gives us this great opportunity for collaboration, innovation, and potential funding for our community. So this is actually a slide out of the Secretary's office, really highlighting the importance of post-crash care as part of the Safe Systems approach, and the idea of providing that right care at the right place in the right time, no delays in our system to get that emergency medical care to that patient, whether it's pre-arrival care by bystanders, by the 911 telecommunicators, or getting that right level of BLS, ALS, etc., first responders with that training to the scene, and then having the ability to get those patients to that critical definitive care. That's incredibly important. So when I talk about the Safe Systems approach, this is a key component of the National Roadway Safety Strategy. And what happens is we have these safe systems collaborate together in order to reduce death and injury on our roadways. So we want to make sure that people are behaving in a more safe manner. We're making sure that our vehicles are safe, we have safer speeds, and the structure of the roadway is safe. But post-crash care is our critical last opportunity to really make a difference in injury severity and reducing deaths on our roadways. 911 plays a part in all 5 aspects of the safe system approach, and EMS is an incredibly critical component of post-crash care. So when we think about it, we have over 1 million EMS clinicians nationwide, making sure that they have the trauma decision trees, the protocols, the most up-to-date evidence-based information to provide that care at the right time, right place, and giving everybody the best opportunity for the best possible outcome after a crash. This is incredibly important within the Department of Transportation and NHTSA, but it's also critical for our communities to have that proper resource, to have that interoperable system of systems that is ready, that has everything they need to do the caliber of care we know they are able to. So making sure that we improve the delivery of EMS throughout our nation, that has been something we've been working on for over 50 years at NHTSA, and we continue to work on. And having this support throughout the department is absolutely critical. Making sure that we improve the availability and the quality of our EMS data, making sure that our EMS clinicians understand that they are key to building this data set, to providing this data that is then used for research, is used to really improve the quality of outcomes, not only for our crash victims, but for any patient. And then making sure that we are taking care of our people. We are supporting those move over laws and education of all of our people who work on those scenes that are high risk on our highways and roadways. And that we are also making sure that they have all the technology, the equipment that they need to keep them safe, not only when they respond to a crash, but anytime they are moving with a patient in their ambulance or moving to a patient with their ambulance. So really understanding that EMS and 911 are absolutely critical for the success of post-crash care. We need to get that right care at the right time to prevent injuries from becoming fatal. When we start to look at this continuum, everything from that 911 center having the ability to provide emergency medical dispatch or bystander care being able to be initiated, to making sure that we can identify the proper location and get the right unit, whether they are across a county line or a jurisdictional boundary, to that right place at the right time, and then utilizing the best evidence-based treatment and transport decision-making tools and taking people to definitive care is really absolutely critical. We know that we have over 1.5 million crashes that our 911 centers dispatch, and 40% of those crash victims were alive but later died. That is not because we didn't provide the best possible care. It's that sometimes we don't have the resources, we have delays, we have challenges. We have an opportunity in that 40%. We have an opportunity to improve and save lives and reduce the severity of injuries. We know that there were a significant proportion of ejection patients. That is probably one of the most challenging things to take care of as a clinician. It also has significant impacts on our workforce mental health. And so it's important for us to recognize how can we not only do the best possible medical care in that responses, but are there ways we can help collaborate on prevention? Are there ways we can collaborate to make sure that our clinicians are never ejected? That should never be a line of duty death for one of our providers. And then improving access to resources for extrication and understanding the impact of serious injury. We oftentimes see research and conversations about fatalities. That's the tip of our iceberg in terms of injury. We want to make sure that we are also looking at those serious injured patients. They have significant consequences from those injuries. How can we reduce the injury severity? How can we reduce the consequences for them? And how do we take the best possible care throughout their emergency care continuum? So we are really going to be focused on working on these incredibly important countermeasures with our highway safety partners, from establishment of emergency medical dispatch in our 911 centers or protocol-driven pre-arrival instructions, making sure that we have the best technology for finding that location and appropriate unit, and then also making sure all of our EMS community is doing the evidence-based work and getting people to the right center. And then we're doing quality improvement and measurement, and we're evaluating our systems and continuously evolving to do the best possible care. Why is this important? Well, we know in the 911 setting, at least, with the most recent data, that only about 47% of our 911 centers across the country have the ability to do emergency medical dispatch. So this is an opportunity for us to engage our highway safety systems, the state highway safety offices, the NHTSA regional offices, and our 911 centers, and our EMS community members to change this, to improve this part of the system and keep these interoperable systems working together. NEMSIS is considered a core highway safety database, and there is the ability to apply for funding within the regional grant programs in NHTSA because it is a critical component of us evaluating and really understanding how to improve post-crash care. So as we move forward and we have these opportunities where the regional offices and not Maryland, you can tell where I used to work, the regional offices are starting to really try to address these challenges. What they're going to be doing with the National Roadway Safety Strategy and the Safe Systems approach is they're going to be taking those regional grants and leveraging this information to improve the outcomes for their communities. And that means that there's the potential for them to fund improvements for both the EMS and the 911 systems at the state level. In order for this to happen, in order for this to work, EMS and 911 has to be engaged with our highway safety communities. We have to have those conversations. Even if in the past those conversations were frustrating or didn't turn out the way we wanted them to, now is a new, fresh start with the Safe Systems approach and the National Roadway Safety Strategy. It's an important time for that engagement to happen. Make sure your highway safety community in your local, state, and at a national level understands what you bring to the table to help them improve outcomes for our community. And by improving our EMS system for our crash victims, we're also going to improve it for all of our patients. So, if you want more information, we have information on 911.gov and EMS.gov, and I am happy to answer questions. Was that fast enough or too fast?
Any questions for Kate on this topic? Thank you, Kate. I'm also aware that you've been doing some work on provider, first responder, mental health, and wellness. I think we'd all like to hear a little bit about that if you wouldn't mind sharing some information with us.
Sure. So this is an incredibly important area for our communities. Both the EMS and the 911 workforce have a lot of needs in terms of taking care of their mental health, but we also are key critical safety net systems for those who are in crisis in our communities. So, as we know, emergency medical services, we practice at the intersection of emergency management, public health, public safety, and healthcare. And if you think about crisis and behavioral health falling within the public health and the healthcare realm, we really are that point of access sometimes for our patients. We oftentimes are the ones who will be called to respond in all different situations, and we're also called to respond when nobody knows who else to call, right? So we are the ones who come in and take a chaotic situation and try to bring the calm and the resources that are needed for the individuals who call. So first I want to talk a little bit about, since there are so many different ways for us to respond to crisis, EMS and 911 systems have been that safety net for a long time. They've evolved at the local and state level how they do this. So there are instances where this is done with co-responder models, bringing in law enforcement, mental health providers, EMS. There are places where the 911 center has mental health providers who sit in the 911 center. There are nurse triage programs. There are community paramedic and mobile integrated health programs that are leveraging resources, bringing mental health providers out in the field. There are places that are using telehealth and access to crisis assessments via telehealth. So this is a really diverse area where a lot of good work is already being done. However, in the last couple of years, there have been some significant changes on the federal, state, and local level to the crisis system. And so while everybody is working on building this new crisis system, it's important for the EMS and 911 community to, again, reach out, connect, build relationships with those who are building the 988 and crisis call center systems, as well as mobile crisis response. So being able to get them to engage with our established systems and understand that the technology in our 911 centers is very, very different than a 988 or a crisis call center, and how that technology difference can cause challenges if there is a need for a response. And then really, how can they understand what we do with our protocols and the challenges in that we are not going to change a protocol overnight. If we do decide to change a protocol to be more interoperable with their systems. And then when they're building new systems, when your hospital builds a new system, when your health department builds a new system, when a behavioral health system builds a new system, we need to be included in that planning. We need to be collaborative so that nothing is built in silos. We don't want 988 and crisis centers to build mobile crisis that is completely siloed from EMS and 911, and where we may have instances where we all show up on scene going, wait, who's responsible? Who's taking this patient or client, and so on and so forth. So right now is the time to really engage with your crisis community at the local, state, and national level. For those who have not heard of 988 or the Suicide Prevention and Crisis Lifeline, it went live July 22nd of last year. What this is, it is a system that if an individual calls 988, it forwards the call to the 1-800 number that previously has existed for the Suicide Lifeline. What they provide is 24/7 access to trained counselors. It routes from that 1-800 number by area code to a local crisis center. If that local crisis center does not answer the call in a timely manner, it routes back up to one of their national call centers. So everything is routed by the area code of the caller's phone, and it does not convey any location information. So they're investing a lot of resources to really scale up these crisis centers to be able to answer the increased volume of calls that they expected and have seen with the launch of 988. If you press 1 when you reach the phone tree, you get the Veterans Crisis Line, so it's direct access to the Veterans Crisis Line. If you press 2, you get a Spanish language version of the crisis line. If you push 3, you get LGBTQ resourced line. If you have a Washington State area code and you push 4, you get Native American, Alaska Native specific crisis line center, but that is only specific to Washington State area codes. So there's been a lot of evolution in the ability to receive these calls and answer these calls. And it's really important for there to be collaboration because this is being deployed and implemented at the state and local level. So while there are a lot of federal resources involved and a lot of collaboration happening, the rubber is going to meet the road at the state level. That's where you're going to have legislation passed that's going to potentially impact EMS and 911. It's where your collaboration is going to be absolutely critical. Now, this is SAMHSA's vision, and I totally took their slide so that you could see where they see this going. So the first phase is to have someone to talk to get the rest of the majority of the country covered by a quickly answered voice, text, or chat through 988, and they have been building that up over time. Their next step is to really get the opportunity for mobile crisis to respond to 80% of the country's individuals. This is where it is absolutely critical that our EMS and 911 systems are engaged with those at the state, local, and national level who are building out this crisis system. If we already have existing resources that are at play, they need to know that, and we need to make sure they're interoperable with what they're trying to build. And then the next phase is to really build stabilization services or places for people to actually go for help. Now, I don't know about you all, but I know in my community where I practice, we need more crisis resources. We need more crisis services. We need more opportunities to have places where we can take people for this care that is not simply the emergency department, because that is not always the right place and the right care at the right time. So this investment and this work is going to be really, really valuable to not only our community and our patients, but to our providers. What's going to be really important is that we are engaged with all of the stakeholders who are potentially planning this out in our communities, and that we really have the opportunity to share what we already do, what we already plan to do, and we recognize people in the community where they are, whether it's where they live or if they're unhoused, and we see them sometimes in those events that can lead up to the moment of crisis, so we have opportunities for upstream intervention in the EMS space. So we have some cool research about how EMS can actually do a really good job of triaging patients and identifying those who can be taken to a not the traditional emergency department, but potentially to an appropriate alternate destination, whether that's the stabilization center or other psychological health center. So we know that there are places where this has already been done and done well. And I just am citing a couple of research studies where the direct transport to a crisis and stabilization center has worked well. EMS has been able to follow a protocol where they were making that medical clearance without bad outcomes. So we know that there's precedent for us to be in this space and to be a helpful piece of this system going forward. So it's important for us to engage. We are excellent at triage. We do a lot of screening. We do screening for stroke and STEMI. Will there come a time when we're also screening our patients for substance use disorder or suicide risk? If we are going to start doing those kinds of screening, I know that our medical directors and all of our clinicians want to make sure that we have the place for them to go and the appropriate ability to provide them with the care that they need. So we need to be invested in helping to build these systems. There's some great success stories. St. Charles EMS in Missouri, they're able to, through telehealth, do a immediate consultation with a master's level social worker for a crisis assessment. And then the paramedic or EMT and the social worker decide, does this person need to go to the hospital, or can we take them to an alternate destination? Can we safety plan and make appointments? What can we do? We know with 988 that only 1.5% of those calls actually are requiring a response by emergency responders. So there's a lot of effective work being done on the phone in that population. When we look at who we respond to, these are more likely to be individuals who are going to need something more emergently. So what can we build in our systems to make that possible? So follow-up after an overdose actually can also have some great suicide prevention opportunities and also ways for us to prevent that next crisis for our patients. West Virginia has a great example of that. Utah Navajo EMS, they require every clinician to have assist training, which is 2 days of training on how to speak to somebody who's potentially suicidal, so that they empower their clinicians to have more training and comfort talking to somebody in that level of crisis. And then I had cited the research with Wake Med's transports to a stabilization center. So we respond to crisis. We have an increased exposure to patients in crisis. We have increased exposure to patients who have attempted suicide. And this can impact the mental health and wellness of our workforce. And we oftentimes expect a lot of ourselves that is above and beyond what the statistics tell us we should expect of ourselves. How often do you have a paramedic who expects to save that cardiac arrest, even though the statistics we know, even in the best system, are very much against them? So one of the things that I think is important for our EMS community to think about is what are we doing proactively for our mental health and that of our crews and our teams. I wish that I could get every EMS clinician when they are in training to establish a relationship with a therapist before they need one. I think sometimes we think that when we need a therapist, when we need that level of care for our people, that it's like we're going to walk in, we go to the first person, and it's going to work. If you have ever walked into a shoe store, tried on one pair of shoes, they worked perfectly, and you were good to go for whatever you were trying to do, then you're probably an outlier. Oftentimes we have to try a couple pairs of shoes, right? Going to that first therapist and having it work out perfectly is not necessarily a realistic expectation, and yet oftentimes that's what happens with our community, and they stop going back and seeking that right person. So EMS clinicians and telecommunicators, we need improved crisis resources for our population. Both telecommunicators and our clinicians are exposed to trauma in what we see or what we hear, but we also are in very high stress situations that then can impact our relationships and how we work with our coworkers. It can impact how we work with our family and interactions with our family. So I was part of a group that started a research study before COVID. It took us a long time. Don't ever have three feds try and collaborate on research. We put out this blog post because we knew that the paper was stuck in clearance. And so this is the link to the blog post that talks about our paper, which thankfully just got published in the Journal of Safety Research. And what this really is it's a call to action. We need better data. We need better research. We need more people to participate in research. What we found through our research is that there is an increased risk of all forms of first responders for suicide. There's an Arizona study that specifically looked at EMS providers. That was the only specific to EMS providers study that we were able to find in our literature review, and it showed that EMS providers were 1.39 times more likely to die by suicide than the public in Arizona. So we also know that telecommunicators have an increased risk of PTSD and symptoms of depression. So then what we found in our research is that among all first responders, past military experience, being male, having relationship or partner problems, workplace problems, physical health problems, including workplace injury, and access to firearms increase their risk of suicide. There are areas where we, as a community, can improve and reduce the risk of our people right now. So this is the research from Arizona, just so that you all can have it. I never want to talk about these difficult things without giving people immediate possible options. So the VA has a lot of great resources. Stress First Aid is something that's free and available on their website, and that is something that any agency could look into if you have no other resources. We have experts in our field. We have published multiple resources within EMS in order to really help us to move forward and improve how we manage our stress, how we take care of our mental health. I think it's important for us to know that there are some free federal resources out there. There are a lot of great resources for EMS. I would say that we need to do better at investing in research so that we actually can highlight evidence-based interventions for first responders and EMS and 911 specifically. We want to really improve the research and data collection to understand their impact so that when we are trying to guide all of our community across the country as to what to do, we have that evidence-based intervention like we use to take care of our patients, to take care of ourselves. What our office is doing right now is we're trying to use the evidence-based guideline model. We're in the second phase of it to build an evidence-based guideline for the mental health of our workforce. Now, it's the first time we've tried to do that using a patient care methodology to apply to occupational health of our workforce. We are in the lit review phase of it, and the next step will be the technical expert panel to really build that out. We're optimistic that that is going to help us have a little bit more understanding of what the research shows and what evidence-based interventions are out there. So to highlight what people can do, really participating in research, if we can get more of our EMS community to participate in research, to become researchers, to advocate for improving our data collection, that National Violent Death Reporting System on which our research and our paper is based has a single narrative block for occupation. So if I were to be a case that they were investigating, that single narrative block would likely say federal bureaucrat. It would not say 26 years, gosh, now I've dated myself, of EMS experience and 11 years of FEMA urban search and rescue experience. I recognize that federal bureaucrats may have risk. I think that my EMS time probably creates more risk for me, but I would not be necessarily captured in that data. So we were working really hard to try and improve that. And I would encourage NEMSAC to consider EMS is the one population that does not currently have a requirement from Congress to have data collection. The FBI for the Department of Justice will be collecting self-report data for suicides among police and 911 telecommunicators. USFA has been charged with collecting data on firefighter suicides. I am actively engaged in conversations to try and get EMS included actually in linked into that FBI data set to try and have as many of them together, but we're still working on that piece. I think it is important for us to make sure that we are capturing that data both in the NVDRS system, but in a self-report way that we could potentially cross-reference and try and build better data systems to understand that. We also need to go upstream. If we're only looking at suicide deaths, we're too late. We've already lost those clinicians or telecommunicators. So it's important that we start at the moment somebody enters our field with improved education and opportunities for high quality continuing education on mental health, crisis, and suicide prevention. At the agency and individual level, how are we empowering our clinicians and their agencies to have plans for prevention, plans for intervention? Does your agency have a plan if you have a paramedic that you identify as suicidal or in crisis? Does your agency have a plan for if you lose a clinician, if one dies by suicide? Do you have a plan before it happens? Unfortunate things to think about, but really important. When my best friend died, our department did not have a plan. We had bickering over who was going to do what at the funeral. Having a plan ahead of time makes your life a little bit less stressful in that moment, but it also helps you to realize that there's stuff that can be done upstream in terms of prevention. We will not prevent everything, but the moment that you have a loss, there are evidence-based postventions that will protect those in your service who are now impacted. For every suicide loss, we expect 6 to be impacted. I would argue in the EMS and 911 community, those numbers are going to be higher when you have a loss within your family. So how are you planning ahead? How are we engaging and participating in research? How many times do we ignore that survey that comes to our inbox, or our clinicians ignore that survey? I would encourage people to consider participating in that. Speak up and destigmatize being proactive and seeking help. How many of your leaders show proactive care seeking? How many of your leaders do proactive work? Take mental health days. Seek a therapist when they need one. Talk about being in therapy. Talk about being medicated for depression if they need to be. We need to overcome the stigma in both of our workforces about seeking help. You can actually come back to work as a paramedic post-suicide attempt. It is possible. You can come back to work after being out of work for PTSD or PTSI. We can do better to prevent all of these things, but we also have evidence-based ways to help our people come back if that is what is in their best interest and what they want to do. So I think it's really important that we empower our clinicians with the education, the knowledge, and the ability to ask the hard questions. We build the planning into our systems so that when they ask those hard questions and get the really difficult answers, they have resources and know what to do. And we want to empower them not just to look out for each other, but to check on their supervisors and take care of their medical directors as well. We know that they're all at risk, and it's important for us to take that moment now and empower our people. There's plenty we can do. We can do much better. We already do a good job of building resilient providers. I think that there's just opportunity for improvement. So there are resources on 911.gov and EMS.gov. I am happy to talk about this all day long. I'm actually doing my doctorate in public health focused on health policy to help us understand the risks that contribute to not only suicide but negative mental health consequences of the work, and how we can get upstream and do a better job of preventing it. So let me know if you have questions.
Kate, fantastic presentation. Thank you so much for the work that you're doing on this. On behalf of the entire council, we're very appreciative of your efforts and certainly your enthusiasm. We will, I'm sure, have some questions to this, but we are in the public comment period, so I do want to pause to allow for our mandated public comment period. Claire, do we have any public comments?
Yes, sir, we do. We actually have one in response to the Kate's talk about mental health. So this 988 doesn't help with in the acute setting. EMS cannot force a person to go to the hospital for an evaluation. Police do not assist in trying to get a person in for evaluation. What happens next? When someone is voicing suicide intent, how do we get to a cool down period if the patient is in immediate crisis and maybe is not able to think through the things during this critical time? I'll let you read it again.
Oh, goodness, that is not a simple question. So there are places where the 988 system is sitting in the 911 center, and there are places that have mental health clinicians who are working with their EMS and working with their 911 center. There are some places that have mobile crisis that comes out to these more acute situations to try and de-escalate things. Where I practice as a paramedic, they will spend hours at a person's home, and the mobile crisis as well as law enforcement have the ability legally in that jurisdiction to do 72-hour holds if necessary. I think the challenge with this is it is so dependent upon your locality and the laws of your locality and the protocols in your locality. So there is not a one-size-fits-all solution. There's a lot of frustration. There's a lot of challenges of how our systems are designed and how we are trained and how we work is not the same as some of the mental health clinicians and community and how they work. And so it can feel really stressful and straining at times when they want us to sit unseen for hours to try and figure out a solution, whereas we know that next call is pending or there are other things going on. So honestly, the best solution is to build those bridges and relationships and improve your training and what is available in your community as a resource. Are there people who can come out and help de-escalate? Are there times when law enforcement is going to force the person to go to the hospital? Are there times when that's not appropriate within an EMS unit? There are times that they might take them in a police car. There are times they take them in an EMS unit. It really varies by location, and it's not a simple answer. The goal in the crisis community is to build the resources available for de-escalation to try and prevent some of those transports to the emergency department for those people who are in enough of a crisis that they need emergent help. There are some knee-jerk reactions that we have built into some of our systems where it's a very gray area. It's not black or white in terms of if they're going to hurt themselves at this moment in time. And that's where having your protocols, your medical directors, and then your behavioral health and your crisis teams actually understanding what everybody is doing and able to do gives you the best opportunities. We're not going to solve and answer all of these situations. We're just going to be able to do the best we can within our protocols and our medical direction.
Thank you, Kate. Clary, are there any other pieces of public comment that have come in?
That's it. That's all we have.
Okay. It's time to bring public comment to close. Thank you for the public for the feedback. We always appreciate that, and we would encourage you to give us questions and feedback whenever possible. We'll take what you've asked in consideration, and we will provide responses if warranted. All responses will be posted on ems.gov. Next, before we go into the future advisory proposals, I know there were a few questions for Kate, so I do see some placards up. I'd like to start with Lisa Baskell. Ms. Baskell?
Thank you so much for the presentation, Ms. Elkins. Super interesting and informative. I wondered if you could say a little bit more when you talked about resources are available to respond, and you provided a list. Are there specific resources for homeless advocacy or homeless resources?
So there's a lot of stuff out there, and the challenge with in terms of homeless resources, there are federal resources, there are state resources, but ultimately EMS needs the local options, right, in terms of homelessness resources. So one of the things that they're trying to build out with local crisis centers and 211 centers, oftentimes, whether the crisis center and 211 center are together or if they're separate. In a lot of communities, they're trying to build out sort of a clearinghouse of what the local resources are. A lot of community paramedic and mobile integrated healthcare systems also have built up these resources of knowing where can I help somebody get food, where can I help somebody get housing. So I would encourage everybody, instead of starting from scratch to build your own for your EMS agency or your community paramedic and mobile integrated healthcare system, reach out to 211, reach out to the crisis centers and crisis community in your jurisdiction. Identify those who are building out these systems, because we have so many people trying to do really good work in this space. And oftentimes EMS, we see these people who have needs, and we can be the people who help connect them into those systems in our community if we know about those resources and have those resources. Happy offline to send some more resources as a follow-up for NEMSAC if that's helpful.
Dr. McMullen?
Thank you. Just a very quick clarification question. You mentioned that 988 pings off of the phone's registered area code, or is it the area code of the tower that receives the call?
That's an excellent question. So it is so my phone number has a 301 area code for my personal cell phone. That is the area code that it will use to direct to a crisis center. So when I was in Denver for a presentation, if I had called 988, it would have gone to a crisis call center in Rockville, Maryland. There is currently no geolocation utilized to direct those calls. 911 is very different methodology for directing the calls. 988 directs the call based on the area code to a local crisis center. I know that the FCC, and we heard from David Firth and his shop, they are looking at geolocation for 988 as well as resiliency of the system. So he is a resource for the NEMSAC if you have specific questions to geo routing or geolocation for 988 and the resiliency of their system.
Dr. Morshidi?
I have that same question and a follow-up to it now. Once they determine that you are calling from, you're not in that same area, are they able to route that phone call to where you currently are?
My understanding is that they don't do a lot of routing to a different crisis center once it lands at a crisis center, unless there is a need to. There are a little over 200 988 crisis centers, but there are more crisis centers across the country that don't participate in the 988 or the Suicide Lifeline program. When the call comes into those centers, their technology is a little bit different, so they would have to know a 10-digit number and have a different. They don't transfer calls the way 911 transfers calls. So that's the other thing, is if they're calling 911 for a response, they're having another person call a 10-digit number to what they believe is the correct 911 center. And then that 911 center potentially has to use exigent circumstance to identify the location of the cell phone if the caller is unwilling or unable to give their location. So it is a very small percentage of the Lifeline calls that come back or need an emergency response, and they classify an emergency response as including mobile crisis. But when they need a 911 response, There have been some challenges with getting the correct location and delays in reaching the correct 911 center and then identifying the location of the individual. The 911 community has been very actively engaged in trying to improve this with both SAMHSA and Vibrant, that's the contractor that manages the National Lifeline Centers. So there's a lot of work being done in that space.
Okay. And just a general comment. Thanks for this work on, focusing on mental health on first responders. They often get left out of that conversation. As you know, as part of the president's strategy, and they had the White House Forum yesterday. I did forward your research paper to them, so to one of the panel members, so that we'll make sure they don't get left out of that conversation. And I would love to see this topic be infiltrated into EMS medical directors' core content, and I can help with that too.
I would love to collaborate, and I will say that we have had really wonderful opportunities engaging with the White House Interagency Policy Committee for Suicide Prevention, and I'm helping with one of the working groups that's working on the revision of the National Suicide Prevention Strategy. So I'm cautiously optimistic that you will see a little bit more representation in some of these national strategies and documents, but the work that EMS is doing on the ground in the field is being noticed and is really appreciated, because we oftentimes are that one last opportunity to save those lives, and the crisis community is doing a lot of work for prevention, and I think we can do better for prevention and we can improve our education across the board, but what you all are already doing every day is making a huge difference.
Thank you, Kate. Next, at this time, we'd like to open the floor up to give each subcommittee chair an opportunity to discuss the advisories that they're proposing for our next meeting for development. So I'd like to start with Ms. Jorgensen on the Professional Safety Subcommittee.
Thank you, Chairman Hayden. Is it okay if I share my screen? So our proposed title is Helicopter EMS Landing Zone Best Practices. So the audience for this advisory would be members of FICOMS and a collaborative approach with the U.S. DOT, including the Federal Aviation Association. The end goal of the advisory for the recommendations would be seeking to identify and promote best practices in helicopter EMS landing zone operations. The intent is to increase patient, helicopter crew, and landing zone ground personnel safety by minimizing chances of crashes. Recommendations may inform training, educational content, and landing zone selection criteria, including pre-designated sites and use of hospital helipads. We will identify key stakeholders: the American Ambulance Association, American Association of State Troopers, other law enforcement agencies, U.S. Fire Administration, International Association of Fire Chiefs, Federal Aviation Association, National Transportation Safety Board, Commission on Accreditation of Medical Transport Systems, and other accrediting bodies, and NASEMSO, the Air Medical Committee. What action will you be asking the target audience to take, and is it in their statutory authority to take action? Target audience to identify and implement strategies based on recommendations and work with federal partners on data gathering. Is there federal guidance already existing? Yes, there is some training guidance that's available. However, more research needs to be done to identify current implementation, the relevance of current recommendations, and identify existing gaps. And will this advisory assist in closing the gap? And that's to be determined after we do further research.
Great, thank you, Ms. Jorgensen. Next up, I'd like to have Mr. Arkins present for the Integration and Technology Committee.
Thank you, Mr. Chair. We're going to tackle the advisory of bidirectional data sharing between EMS and hospitals. Our audience in this is going to be FICOMS and HHS. Currently, there is some legislation out there surrounding this, but it is not really clear. Each lawyer seems to interpret it a little bit differently. And so part of this will be to demonstrate that there is true guidance out there, and that maybe HHS can deliver that guidance in a more in a fashion that's easier to digest and that's consistent across the board. So hospital A lawyer says, "Oh no, HIPAA says you can't do that." Hospital B says, "Yep, we'll give you everything you want." So I just think that needs to be real. It needs to come down at the legislative level because if you do read the HIPAA law, it does become confusing at certain points. I think we as EMS advocates, we all know if you look back, the Institute of Medicine report back in 2006 mentioned this happening. So we're 3 years away from being 2 decades out of this being a good idea. So we'd like to move this needle a little bit forward by working with FICOMS and HHS. Like I said, there is some guidance already out there, but I don't think it's clear as a clear standard. So this hopefully will close that gap and we can actually get more data feedback, which will lead to better research and clinical aspects.
Thank you, Mr. Arkins. Next up is Ms. Baskell, Chair of the Preparedness and Education Subcommittee. Ms. Baskell?
Thank you, Chairman Hayden. We're considering a new topic on EMS response to active threats, particularly active shooter incidents. We've really just started the conversation on this topic. We'd like to propose to do some research to see if it's a topic the council would like to take up. Topics or considerations would include, perhaps a look at EMS response to active shooter incidents in a healthcare setting, the unique challenges that a healthcare setting provides as far as having fixed patients that wouldn't be able to move or leave the area to seek safety elsewhere, and who would be managing, patient care during those settings in time of a threat and EMS response. Very early discussion, but looking forward to having more time to research this topic and consider if we want to move it to a full advisory.
Thank you very much, Lisa. Next up is Dr. McMullen, Chair of the Equitable Patient Care Committee. Dr. McMullen?
Thank you very much. Our subcommittee meeting was this morning where we discussed a few things for the first time. Our current advisory, I believe we can even consider it to go backwards to a proposal. So I will mention that here as well as one other new one. The current one that we've been working on that we are reinvigorating and going back to the beginning is an assessment of equitable access to EMS based on population density, with the understanding that access to care is multifactorial, and it starts with the 911 call through delivery to definitive services, and that there are several layers involved of what local communities may or may not have, and an impact based off of their population density. A lot of the work that's been published has been spotty and disease-centric, such as access to stroke centers, without a comprehensive look to help identify, for communities to help identify where their needs most are. A new topic that has come out of this morning's subcommittee meeting is currently titled Mitigating Medication Supply and Device Shortages. As we all know, for the last decade or more, we've been facing rolling shortages of critical medications and now supplies and devices, everything from normal saline through ambulances and to ED pads. While there is some information available through the FDA on what drug shortages there are and even extension of expiration dates, that does not necessarily apply to our supplies and devices. So the overarching goal is to help better define this and to come up with recommendations of how to mitigate the impact to high-quality patient care. Thank you.
Thank you, Dr. McMullen. Next is the Sustainability and Efficiency Committee. Mr. Paul Brennan, Chair.
Hello. The subcommittee will be looking at strategies for providing mobile integrated health and community paramedicine reimbursement and financing. The goal of this, of course, is we know there are mobile integrated health systems in place across the country, with some systems having much success in reimbursement and other systems having little to no success in any funding or reimbursement. So we'll be looking to work with FICOMS with an end goal of an advisory or recommendations on how we can work with federal partners to come up with standards on some type of reimbursement and funding opportunities for mobile integrated health and community paramedicine.
Thank you, Mr. Brennan. Next up is Mr. Pfeiffer, Chair of the Adaptation and Innovation Committee. Mr. Pfeiffer.
Hi, thanks very much. Our committee is going to be looking at best practices for the use of body cameras in EMS. Kind of on its face, it seems like a relatively straightforward issue that recordings from body cameras worn by EMS providers would be treated the same way that any protected health information or identifying information would be treated under HIPAA. But there are some challenges that are a little bit more complex once you start to really scratch the surface, including things like, is the primary purpose of those recordings quality assurance, in which case it might be legally protected from discovery and things like lawsuits, or is the primary purpose something else, in which case it would be part of the overall public record, so on and so forth. So there are some complexities to it, and that's just one example that probably deserve to be fleshed out and some recommendations made to the EMS community. And so I think the primary audience may just be NHTSA and the Office of EMS for distribution to EMS agencies, EMS providers. And there are some agencies that are using these cameras already. There are some healthcare systems in which body cameras are present within the care environment. So there are some examples that we're going to be looking at. But the rest of the questions probably remain to be explored. So we look forward to digging into it and seeing if we can put out some useful guidance. Thanks.
Thank you, Mr. Pfeiffer. We'll be voting on advancing these shortly, but I'd like to take about 10 minutes to have a conversation about strategic planning for our future meetings. We had some dialogue over the last 2 days speaking about things that we all felt were important for the council to take on, or folks that we thought it would be important for us to hear from. And I'd like to open the floor to the membership to share any groups or entities you think would be important entities that we should ask for either presentations or information on to help us better educate ourselves into where there may be needs within the EMS community. I'll start. I think we had several of us had a conversation about perhaps the need to have a better understanding for how territorial EMS is handled in the country today, and where there may be opportunities for the NEMSAC to help with advisories that could help benefit them. And one of the things that I thought would be important, and I hope you do as well, would be to perhaps get someone from a territory in to help better educate us, albeit I have very little education in this, so I thought it might be a great idea. We've had presentations by the IHS before as well, but I think that also getting information on reservations and some of the care islands that exist for EMS within reservations and territories, I think would be very important. So if no one's opposed, I would recommend that we schedule some presentations by our territorial and perhaps our Indian Health Service agents to come in and do some presentations. Does that meet everyone's approval? Mm-hmm. Yes? Anyone else? Other ideas?
I'd like to see like NIMSIS come in, talk about the data set, how it's utilized, how we can utilize it to actually help our advisories out. I think that would be a good opportunity for them. Also, maybe some of the other, like the American Ambulance Association, give us some ideas of what types of things are they working on, how we can help support them.
That's right. The AAA is a great idea. Thank you, Tom.
That was yours.
Yeah.
You just didn't mention it.
I didn't. Other thoughts or ideas? Apparently I talk very fast, so we'll have a lot of time at our upcoming meetings for more presentations. I think one of the other things that came up yesterday, which I really think is a great idea, is the development of an advisory dashboard that allows us to track the progress of our advisories through each phase, so that any member of the committee can go in and look. Because we all have access to all the meetings at this point through Basecamp, I think it makes sense for us to be able to see at what point each of the advisories is at and where we could potentially add value, whether we're official members of those subcommittees or not. Other thoughts or ideas for our coming meetings?
I'll just drop mine in Basecamp.
I'm sorry?
I already do that, so I'll drop it in Basecamp so everyone can see it. I just do it personal, but I'll do it for everybody now.
All right.
Thank
So Clara's already fixed it.
Check.
So now we have room for another presentation. Anyone else? Okay, and obviously we can have this kind of conversation at each subsequent meeting to make sure that we have a full plate when we come here and we get on with the business of helping our industry and the patients we serve. Next up is the vote to accept the advisory proposals so that these new proposals that were just submitted and shared can move to the next level. So, Ms. Jorgensen, on behalf of Professional Safety, do you have a motion?
Yes, I do. I would like to make a motion to accept the helicopter EMS landing zone best practices as an advisory topic to begin research on.
Is there a second?
Second.
All in favor, please unmute and say aye.
Aye.
All opposed, please unmute and say nay. Any abstentions? Motion carries. Thank you. Next, Mr. Arkins, on behalf of the Integration and Technology Committee.
Thank you, Mr. Chairman. I'd like to make a motion that we take the bidirectional data sharing between EMS and hospitals as the next step and into research for our next potential advisory.
Is there a second?
Second.
Second. Thank you, Dr. McMullen. All in favor, please unmute and say aye.
Aye.
All opposed, please unmute and say nay. Any abstentions? Thank you. Motion carries. Next is Ms. Basco with the Preparedness and Education Committee. Ms. Basco.
I'd like to propose that we take the topic of EMS response to active threats as a new topic for consideration for research for potential advisory.
Do we have a second?
I'll second.
Second.
Dr. Kohler, thank you for the second. All in favor, please unmute and say aye.
Aye.
All opposed, please unmute and say nay. Any abstentions? Motion carries. Thank you. Next is Dr. McMullen, Equitable Patient Care.
Thank you. I would like to take mitigating medication supply and device shortages to a research phase for potential new advisory.
Is there a second? Second. Thank you, Dr. Quintero. All in favor, please unmute and say aye.
Aye.
All opposed, unmute and say nay. Any abstentions? Thank you. Dr. McMullen, I think you have a second as well, right?
The other one is already on the books.
Okay. All right. Next up is Sustainability and Efficiency. Mr. Brennan.
I propose we tackle the strategies for providing mobile integrated health, community paramedicine, reimbursement, and financing as a topic to look for a possible advisory or recommendations.
Is there a second?
I'll second it.
Thank you. All in favor, please unmute and say aye.
Aye.
All opposed, unmute and say nay. Any abstentions? Thank you, Mr. Brennan. Mr. Pfeiffer, Adaptation and Innovation.
I propose that we take best practices for the use of body cameras in EMS into the research phase.
Do we have a second?
A second.
Dr. Orgonzola, thank you for the second. All in favor, please unmute and say aye.
Aye.
Any opposed, please unmute and say nay. Any abstentions? Motion carries. Well, we've had a pretty productive 2 days. We've welcomed a lot of new friends, and I think, speaking on behalf of the returning NEMSACers, we are extremely excited by all of your presence here and certainly your enthusiasm and your engagement. So we're very happy to have you here, and I think your value is already being seen on this council. Thank you to the members of the public who have joined us for our meeting today. Thank you again to the council representatives for your participation and your willingness to serve and serve your respective sectors. New representatives, again, welcome aboard. The new energy in the room is quite palpable and exciting. I've had a great couple days, as I know we all have, getting to know all of you and your amazing backgrounds. I can't wait to see what happens over the next couple years. The next meeting is tentatively scheduled for August 2023. A Federal Register notice will soon be published, officially announcing the dates of the August meeting. Additionally, I believe it is customary for the NHTSA Office of EMS to also send out to ems.gov delivery meeting announcement to those who subscribe to communications from ems.gov. Be on the lookout for those two publications. If there are no other discussions or business to discuss today, I will open the floor for a motion to adjourn. Thank you, Mr. Tagman. We have a motion to adjourn. Is there a second?
Second.
Thank you. And if all in favor, please unmute and say aye.
Aye.
If anyone is opposed, unmute and say nay. And if there's any abstentions, we stand in recess. Thank you.